What if the pill you take every night to help you sleep, the medicine you take for allergies, or the tablet you use for bladder problems could be quietly affecting the way your brain functions? That question should get your attention, because memory loss is not always just about aging. Sometimes the brain is responding to something else. Sometimes the problem is dehydration. Sometimes it is poor sleep. Sometimes it is depression, vitamin deficiency, infection, an untreated hearing problem, or another medical condition. And sometimes the overlooked factor is sitting inside your medicine cabinet. Now, before you become frightened by that statement, I want to make something very clear. This is not a message telling you to stop your medication. It is not. Many medications are life-saving. They control blood pressure, they prevent strokes, they treat infections, they manage depression, they relieve severe pain, they control dangerous heart rhythms, they protect the stomach, they help people sleep when other treatments have failed. The question is not, are medications bad? The real question is much more intelligent. Could a medication, especially when used for a long time, at a high dose, or in combination with several other medications, affect the brain in ways that we should be watching? And in some cases, the answer is yes. The brain is one of the most chemically sensitive organs in the human body. Every thought, every memory, every movement, every emotion, and every moment of attention depends on an incredibly precise balance of chemical signals. A medication that changes one of those chemical signals can sometimes change the way you think or remember. That effect may be temporary, it may be reversible, it may be related to dosage. It may only happen when several medications are taken together, and in some cases, researchers have found an association between long-term exposure and a higher risk of dementia. But there is an important distinction here. An association does not automatically mean a medication caused dementia. Older adults who take certain medicines may already have conditions that increase their risk of memory problems. People with anxiety may be more likely to receive sedative medications. People with bladder disease may be prescribed anticholinergic drugs. People with sleep disorders may use sleeping pills. Those underlying conditions can complicate research. So today, we are going to look at 9 common medication groups that deserve attention when we are thinking about brain health and memory. And I want you to listen especially closely to the last part of this discussion, because one of the most important things you can do for your brain is not simply taking another supplement. It is knowing exactly what is already going into your body. Let us start with one of the biggest concerns. The first group is anticholinergic medications. The word may sound complicated, but the basic idea is actually quite simple. Your brain uses a chemical messenger called acetylcholine. Acetylcholine is deeply involved in attention, learning, memory, muscle control, and many other functions. Certain medications block the effects of acetylcholine. They are called anticholinergic medications. Doctors have used medications with anticholinergic properties for many years because they can be extremely useful. The problem is that when these drugs enter the brain, especially in older people, they can sometimes interfere with normal cognitive function. Imagine your brain as a busy communication network. Messages are constantly traveling from one nerve cell to another. Now imagine placing small barriers along the communication routes. The message might still get through, but it may arrive more slowly, or it may become incomplete, or the brain may have to work harder to interpret it. That is one reason anticholinergic medications can sometimes cause dry mouth, constipation, blurred vision, urinary retention, sleepiness, and confusion. And in older adults, the brain can be more sensitive to these effects. Research over recent years has raised particular concerns about long-term or high cumulative exposure to anticholinergic medications and dementia risk. That does not mean every person who takes an anticholinergic medication will develop dementia. Far from it. But it does mean that the total anticholinergic burden matters. And this is where things get interesting, because many people do not realize how many everyday medications have anticholinergic effects. You may know one drug by its brand name, but another medication for a completely different problem may have a similar effect. A person may take one medicine for allergies, another for bladder problems, another for sleep, another for depression, another for dizziness. Each medication may seem unrelated, but their effects can add together. Suddenly, a person who is taking several individually familiar medications may have a much greater overall anticholinergic burden. This is one reason medication reviews are so important, and there is a particularly important example in the world of allergy and sleep medicines. Some older antihistamines, especially first-generation antihistamines, can have significant anticholinergic effects. Diphenhydramine is a familiar example. Many people recognize it as an allergy medicine, but it is also found in some over-the-counter sleep products. This can create a very important problem. A person may think it is sold without a prescription, so it must be harmless. But over-the-counter does not mean risk-free. A medication can be available on a pharmacy shelf and still have powerful effects on the brain. In an older adult, a strongly sedating antihistamine can contribute to confusion, dizziness, slowed reaction time, balance problems, and falls. And when someone becomes confused after taking a medication, the family may conclude that dementia has suddenly appeared. But sometimes what looks like dementia may actually be a medication effect or a combination of medication effects. That is why timing matters. When did the symptoms begin? Was a new drug started? Was the dose increased? Was another medication added? Did the confusion become worse after a sleeping pill? Did memory problems appear after a bladder medication was introduced? These questions can be medically important. The second medication group we need to discuss is bladder medications, particularly certain antimuscarinic drugs used for overactive bladder. This is an area that many people never connect with memory. You might think a bladder medication has nothing to do with the brain, but some medicines used to relax the bladder work by affecting acetylcholine signaling, and some of these drugs can enter the brain. Oxybutynin is one of the best-known examples. For some patients, these medicines provide tremendous relief. They can reduce urgency, frequent urination, and accidents. That benefit matters. Quality of life matters. Sleep matters. Embarrassment and anxiety around bladder control matter. So this is not about declaring the medication bad. The issue is whether the same benefit could sometimes be achieved with a medication or treatment approach that has less impact on cognition. For certain patients, doctors may consider alternatives that work through a different pathway. And that is the kind of conversation worth having. Not, I saw a video saying this medicine causes dementia, so I stopped it. Instead, doctor, I am concerned about my memory. Could any of my medications be contributing? Are there alternatives with less anticholinergic activity? That is a much safer and more productive conversation. The third group is another medication family that can be overlooked because people often think of it simply as a depression treatment. Tricyclic antidepressants. Examples include amitriptyline, nortriptyline, and several related medications. These drugs can be effective for depression and are also sometimes used for nerve pain, migraine prevention, or other conditions. But some tricyclic antidepressants have significant anticholinergic effects, and that means they can become part of the overall cognitive burden. A medication does not have to be prescribed for a brain disorder to affect the brain. That is an important lesson. The nervous system does not care what problem the doctor intended to treat. If a drug changes neurotransmitter activity, the brain can respond. For some people, that response may be helpful. For others, especially older adults or people already vulnerable to cognitive problems, it may cause unwanted effects. A person might feel unusually sleepy. They may become less alert. They may have difficulty concentrating. They may feel mentally foggy. They may forget conversations. They may struggle to find words. And because these changes can develop slowly, family members may not immediately recognize the medication as a possible contributor. They may simply say, "Mom is getting old," or "Dad is becoming forgetful." But aging alone should not automatically explain every change in cognition. Healthy aging can involve taking longer to remember a name or occasionally forgetting where you placed your keys. Dementia is different. It involves a persistent decline in cognitive function that interferes with daily life. Medication-related cognitive impairment can be different again, and sometimes the two can overlap. That is why a careful evaluation is so important. The fourth group is one that has received enormous attention in dementia research: benzodiazepines. These medications include drugs such as alprazolam, lorazepam, diazepam, and clonazepam. They are commonly prescribed for anxiety, panic symptoms, insomnia, muscle spasms, and other conditions. They work partly by enhancing the activity of a calming chemical system in the brain. That can be extremely effective. If someone is experiencing severe anxiety, a benzodiazepine may make a dramatic difference. But what calms the brain can also slow the brain, and that is where the problem can begin. Sedation, slowed reaction time, reduced alertness, problems with balance, impaired attention, memory difficulties. For an older adult, these effects can be especially important because falls are not a minor issue. A fall can result in a broken hip, a head injury, a hospital stay, loss of independence, and sometimes a cascade of health problems. But what about dementia itself? Research examining benzodiazepines and dementia has produced concerning signals, with observational studies frequently finding associations between use and dementia risk. At the same time, the evidence is not strong enough to say that benzodiazepines directly cause dementia. That distinction matters. People prescribed benzodiazepines may already have anxiety, sleep problems, depression, medical illness, or other factors that influence dementia risk. Researchers call this confounding. So it would be irresponsible to tell everyone benzodiazepines cause dementia. That is not what the evidence proves. What the evidence does tell us is that long-term use in older adults deserves careful medical review, especially when the drug is being used every night for months or years. And this leads to an important question. If the medicine was started 10 years ago, is it still necessary today? Sometimes the answer is yes. Sometimes it is no. Sometimes the medication can be reduced gradually. Sometimes another treatment is more appropriate. Sometimes stopping is unsafe. A person who has taken certain benzodiazepines regularly should never decide to quit abruptly without medical advice. Sudden withdrawal can be dangerous. So the solution is not panic. The solution is review. The fifth group is closely related because many people think of them as a completely different category. Sleeping pills, known as Z drugs. Examples include zolpidem, zaleplon, and ezopiclone. These medications were designed to help people sleep. And sleep is not optional. Sleep is essential for brain health. During sleep, the brain undergoes important processes related to memory, learning, emotional regulation, and metabolic waste clearance. So when someone cannot sleep, the problem is real. But using a medication to force sleep can sometimes come with trade-offs. These drugs can cause next-day drowsiness. They can impair coordination. They can increase the risk of falls. And some people experience unusual behaviors or confusion while taking them. In older adults, this becomes even more important. There is also research investigating whether long-term exposure to certain sedative hypnotic medications is associated with dementia. Again, the evidence is not simple. We cannot say that taking a sleeping pill automatically causes Alzheimer's disease. But the broader lesson remains. If a medication is repeatedly altering alertness, attention, or cognition, it deserves a periodic review. And sometimes the most effective long-term strategy for sleep is not simply increasing the sleeping medication. It may be treating the reason the person cannot sleep. Sleep apnea, pain, restless legs, depression, anxiety, too much caffeine, irregular sleep schedules, poor light exposure during the day, lack of physical activity, certain medications taken at the wrong time. When the root problem is addressed, the person may need less medication, and that can be a much healthier long-term strategy. The sixth group is especially important because it includes medications that are sometimes prescribed to older adults for behavior, agitation, hallucinations, or psychiatric symptoms. Antipsychotic medications. Examples include risperidone, olanzapine, quetiapine, and related drugs. These medications can be necessary. For some people with severe psychiatric illness, they are essential. In certain situations involving serious agitation, psychosis, or dangerous behavioral symptoms, medication may be part of appropriate treatment. But antipsychotics come with significant risks in older adults, and the concerns become especially serious in people who already have dementia. Research has repeatedly linked antipsychotic treatment in people with dementia with increased risks of serious adverse outcomes, including mortality and cerebrovascular events. This is why these medicines require careful prescribing, careful monitoring, and regular reassessment. There is another important distinction. Antipsychotics are not simply dementia drugs. They do not cure dementia. They are sometimes used to manage severe behavioral and psychological symptoms, and guidelines generally emphasize non-drug approaches first when appropriate. That could mean looking for pain, checking for infection, treating constipation, improving the environment, reducing noise, addressing loneliness, improving sleep, providing reassurance, making sure hearing aids and glasses are working. Sometimes the behavior is communication. A person with dementia may not be able to say, "I am in pain." Instead, they become agitated. The behavior is a clue, and if we treat only the behavior with a sedating drug without investigating the cause, we may miss the real problem. The seventh category brings us back to anticholinergic effects, but this time in a medication group that many people may not associate with cognition at all. Certain medications used for Parkinsonian symptoms, tremors, or other movement problems can have anticholinergic properties. Drugs such as benzodiazepines are examples. These medicines can sometimes improve specific symptoms, but in older adults, anticholinergic effects can become problematic. Confusion, dry mouth, constipation, blurred vision, urinary retention, difficulty thinking clearly, and sometimes a person becomes so confused that the family thinks the dementia has suddenly accelerated. That is why medication effects should always be considered when cognition changes unexpectedly. One of the biggest mistakes families can make is assuming that every episode of confusion represents permanent brain damage. It may not. A sudden change in mental status can be caused by a medical emergency called delirium. Delirium can happen with infection, dehydration, low oxygen, metabolic disturbances, medication changes, pain, or hospitalization, and it is very different from the slow progression of dementia. So when an older adult suddenly becomes confused, that deserves medical evaluation. Do not simply say, "This must be Alzheimer's." Sometimes there is something treatable happening right in front of you. The eighth category is medications that affect the nervous system in other ways, including some anticonvulsant and nerve pain medicines. This category requires special nuance. Some of these medicines can cause sleepiness, dizziness, slowed thinking, or problems with concentration. Gabapentin is a familiar example. It can be extremely useful for certain kinds of nerve pain and other conditions. But in some older adults, especially those taking multiple medications that depress the nervous system, it may contribute to cognitive slowing or sedation. Does that mean gabapentin causes dementia? No. The evidence does not justify such a blanket statement. But when a person develops new cognitive symptoms after a medication is started or increased, it is reasonable to ask whether the medication could be contributing. There is a bigger idea here that deserves attention. Your brain does not experience medications one at a time. It experiences the total combination. Imagine an older adult taking 6 or 8 medications. One makes them sleepy, another lowers blood pressure, another affects acetylcholine, another slows the nervous system, another changes fluid balance. The combination may produce a result that no single medication would create by itself. That is polypharmacy, and it is one of the reasons medication review becomes increasingly important as people age. The ninth and final group is probably the one that surprises people the most: proton pump inhibitors. These are medications such as omeprazole, esomeprazole, lansoprazole, and pantoprazole. Millions of people use them for acid reflux, ulcers, and other gastrointestinal conditions. And for years, headlines have suggested that these medications might be linked to dementia. But here is where we need to be extremely careful. The evidence is mixed. Some observational studies have reported an association. Other studies have not found a meaningful association. More recent reviews have concluded that there is no consistent, robust evidence proving that proton pump inhibitors cause dementia. So why mention them? Because the topic demonstrates exactly how medical science should work. We should not take one alarming study and turn it into a frightening internet headline. And we should not ignore scientific uncertainty either. A medication should be used when the benefits outweigh the risks. If someone has a strong reason to take a proton pump inhibitor, they should not stop it simply because they saw a video claiming it causes Alzheimer's disease. The correct approach is to ask whether it is still needed, whether the dose is appropriate, and whether long-term treatment is medically justified. That is a much more intelligent question. And this principle applies to every medication we have discussed today. The goal is not to create fear. The goal is to create awareness. Because there is another side to this entire conversation that is rarely mentioned. The medication you are afraid to take may actually be protecting your brain. Think about blood pressure medication. Uncontrolled high blood pressure can damage blood vessels in the brain. It can increase the risk of stroke. It can contribute to vascular cognitive impairment. So avoiding a blood pressure medication because you are afraid of side effects could, in some situations, increase rather than decrease your long-term risk. The same principle applies to other diseases. Diabetes, high cholesterol,